introduction.
Look, thanks. There's no way I'm going to try and attempt to give John's talk, but John was having dinner, John and Annette were having dinner with us last night. Unfortunately, he was taken unwell quite acutely, but he's okay, but certainly not well enough to attend. And I thought it was just and he's at 3 o'clock in the morning. This shows you how committed John is. At 3 a.m., I wasn't awake, I must add, I was 10 minutes later, but at 3 a.m. he sent me his talk. And so I thought it was only fitting that I just try to say what he's trying to do. I'm not going to try and give his talk, but what he's trying to set out to do with his colleagues is establish a clinical quality registry to try and once again meet the targets that Jane has been talking about to improve outcomes, reduce mortality in women with ovarian cancer. And they've done this very successfully in a number of other tumour types, and I'll talk very briefly using his slides, which I only saw very transiently this morning, about a clinical quality register. And so basically what this does is collect uniform data to measure performance of a practitioner or a health service and try and benchmark that across different sites and in different institutions. And this hopefully will empower health service providers to improve patient care and outcomes. And indeed they've shown that works very successfully in prostate cancer, and I'll show you some of these data in a moment. So he talks about a clinical quality register as being a data spine, and they aim to capture the whole population. They don't try and cherry pick, and they're measuring outcomes and trying to link outcomes to care, and this is a long-term project. And then there's a lot of research that can be tacked onto that, as you can imagine. And obviously collecting the data is critically important. It should be uniform, minimal amount of data, because obviously if you try and collect too much, it's going to fail. Epidemiologically sound, reliable, and individually identifiable. And he makes the point that good registries provide quality assurance that's sensitive, they detect of unwarranted variation. And this is really important, and you'll see why in a moment how successful it's been in prostate cancer. And essentially the whole impetus behind this is to improve patient care and to look at a way that this can be done across the community. I'm going to skip that. And the rationale for this is that there is significant variation in cancer care. There is significant variation in clinical outcomes. And I'll show you a couple of my own slides that I just chucked in at the last minute to support this. And something also very close to my heart is patient-reported outcomes, which I think in many respects is more sensitive than clinical outcomes, and are going to be collecting this as well. And the aim is to try and benchmark ovarian cancer care for the first time, not only within Victoria, where the pilot study will be carried out, but eventually, hopefully, throughout Australia and internationally. And this clearly can generate hypotheses for further research. It can be used to create important questions with respect to clinical trials, and indeed can be expanded to other gynecological cancers. And they have got a lot of interest, I understand, from clinicians and also from ASGO, which without ASGO support this would not go ahead. So he makes the point, and I think this is probably changed, I'm sure, in the UK, but a while ago UK figures were certainly survival was significantly lower in the rest of Europe. That's changed because of significant changes in the approach to management. But there's still often, right across the board, not just in the UK, but in Australia and all over the world, often inadequate surgery, inadequate or inappropriate chemotherapy, and there's lots of room for improvement. And this is my slide that I used for another talk, and I entitled it, Improving Outcomes in Ovarian Cancer. What do we have control over? And I think more than we realize. Because there are many things that we actually can do something about, including optimal staging, optimal pathological diagnosis, selecting patients for BRCA testing, optimizing chemotherapy, identifying specific subsets who may be at high or lower risk, access to clinical trials, optimal supportive care, prevention through risk-reducing surgery, secondary surgery and identifiable in certain circumstances, optimal management of the recurrent setting, timing of treatment, and both avoiding over-treatment and under-treatment. And this is all within our grasp. We can do all this. And so if we all do it better, I think it will improve outcomes. And I think this is just a really interesting example of looking at the variation in outcomes, and look at those differences. They are enormous differences. Looking between adherence to guidelines, and this is across race, and I guess obviously socioeconomic factors in the US. Now at the very bottom are non-adherent blacks, and at the top are adherent whites. Now there is not that big a difference in the biology of ovarian cancer between blacks and whites or Asians or any other ethnic groups. This is because of inadequate care. And if you can focus and you can change that, you can make a big difference now, not tomorrow, not in 20 years' time, not with fancy new expensive drugs with lots of side effects, just by doing it properly now. And this is what John is trying to do. And this is once again another slide I chucked in showing the difference between being managed in units that see a lot of patients with ovarian cancer and those who don't. Big differences. If we had a clinical trial with those kind of differences, you know, we would be on our way to Copenhagen. But this is really impressive. So this is, I think, the impetus for what John is trying to do. So I'm not going to give his whole talk, but I wanted just to tell you what he's doing, and they have done this very successfully in prostate cancer, and they've been able to show, and I think I better backtrack with the prostate. I don't know even how to do that. But anyway, prostate's been very successful. They found units where they had a very high incidence of positive margins in certain hospitals, and they went back. They spoke with the surgeons and the fellows. They retrained them, and then their positive margin rate went right down to the community expectation. They were able to avoid over-treatment in low risk and under-treatment in high risk. And this has all just been done in Victoria through these registries. And I think I went too fast, but anyway, and I skipped through a couple of his slides, but that's what John's trying to do, and obviously he would have given a much better talk, but I thought it was only fitting that people understood what he was doing, because I think you will be hearing more from him in due course. They've applied for a grant, and hopefully they'll get one to do a pilot study in Victoria, and then it'll be rolled out across the country. So on behalf of John, that's it. Thank you.